A very good afternoon to one and all present here. I am Arpita, the moderator for today's session from IGCP Group. The topic that we have chosen today is infection control in healthcare settings. Now, infection control in healthcare settings focuses on preventing the spread of infections within hospitals and clinics. It involves implementing protocols such as hand hygiene, sterilization of instruments, use of personal protective equipments, and isolation procedure. Effective infection control reduces health associated infections, protects patients and staff, and improves overall healthcare outcomes. So, we have with us none other than our very own and very prominent Dr. M. Balasubramanian sir, who will be discussing on the topic. But before that, I would like to just welcome sir and introduce him to the audiences. Sir is a former State Secretary of President and National Vice President of IMA, past Chairman of Nursing Home Board and Paramedical Wing of IMA Tamil Nadu State. So, with this very brief introduction of sir, I would now request him to please start with the session. Over to you, sir.
Thank you, Arpita. Thanks to IJCP for giving me yet another opportunity after a small gap of 3 months due to my own commitment. Thanks. Dear friends, I would like to speak about infection control in healthcare settings, which is expected from all quarters from the hospital and the healthcare workers. Adherence to infection prevention and control practices is essential to providing safe and high quality patient care across all settings where health care is delivered. So everybody expects safety and high quality from us. The core practices which I am going to enumerate should be implemented in all settings where health care is delivered. These venues include both inpatient settings, that is ICU, acute or long term care, and outpatient settings like clinics, emergency care, ambulatory surgical centers, imaging centers, dialysis centers, physical therapy and rehabilitation centers, and even alternative medicine clinics. In addition, these practices apply to healthcare delivered in settings other than traditional healthcare facilities, such as home. Even in the home, we have to, the people should maintain hygiene, assisted living communities, pharmacies, and health camps, etc. So, what we mean by HAI? Everybody know hospital acquired infection. Only for the past 2 or 3 decades we are mentioning this. Before that, we were mentioning these infections as nosocomial infection. We used to write in the case sheet pneumonia nosocomial infection. We didn't accept the responsibility openly that the patient got the infection after admission into the hospital, and we were trying to escape by using the Roman uh, nomenclature of nosocomial infection. So, the importance of addressing this hospital-acquired infection is of paramount importance. And everybody, they want quality and safe care. And I'm going to present you a set of slides where we discuss in depth of these infections. The types of hospital-acquired infections, to name it, most common is the catheter-associated urinary tract infection, CAUTI. Let me narrate a clinical scenario. A 78-year-old male was brought to the casualty in the late hours of the day with pain over the lower abdomen. He has not passed urine since morning or even late night. And the duty medical officer saw and palpated and saw the bladder was full and it was extended to the lower abdomen, suprailiac fossa region. So he said this urine has to be first drained out. So he instructed the staff nurse to have a urinary catheter and drain out the urine which has been there stagnated in the urinary bladder. And the staff nurse passed this urinary catheter and drained not one tray of kidney tray full of urine, but about two full kidney tray, as well as the little more in the third tray. See, each kidney tray, the standard capacity is 500 ml. So he had 1200 ml. Once we have 250 ml of urine, the person will have the sensation of passing urine. When it exceeds 350 cc in the bladder, it becomes painful. So imagine this old man bearing the pain from 350 cc to 1200 cc of urine there. So he had a good relief and blessed the sister, staff nurse. God bless you. Now I am being totally relieved. The duty doctor came and said, let the catheter be there, but we have to find out the cause why urine has collected and stagnated. Probably this age you will be having enlarged prostate, benign hypertrophy of the prostate. So you'll be there in the observation. Tomorrow morning we will do the ultrasound and find out how is your prostate. So next day, 9 o'clock or 10 o'clock, this he was taken to ultrasound and found that he had the diagnosis was right, benign hypertrophy of the prostate. And this doctor said, having been here, we'll get the opinion of the urologist. So urologist came after 1 or 2 hours and examined, and he said, you may get this retention of urine now and then, so unless until we remove part of this prostate. So we have to do this one, small surgery where we chop off this prostate. Let's see. So surgery was fixed for the next day, and the anesthetist came and saw, and everything. He was a few blood tests were done, and he was ready for the surgery. But in the night he had shivering and developed fever. So he had acquired urinary tract infection. So how he got this infection? He was not incubating the infection before admission, or he was not in the asymptomatic region. He was totally healthy other than this retention of urine. So this infection has been acquired by faulty technique of urinary catheterization. And the blessing to the sister became curse. He started to curse this sister. Initially he had blessed and sister. So this is a urinary tract infection due to catheter associates. Right. Next, we go to the surgical site infection. Here also, I would like to narrate a small incident. Say 70-year-old male came to the hospital for again pain in the abdomen and groin. He already had a hernia small problem, and in here he had this hernia coming out but not going inside. So the surgeon examined and said this hernia has to be operated, and we will do it, and we will discharge you on the third day, and you have to come on seventh day to remove the sutures. So surgery was done next day, and when he was about to be discharged on the third day, he had redness over the surgical site and developed fever, and the surgeon advised him to be in the hospital for a few more days, and instead of tablets and capsules, injections were given, antibiotics were given parenterally, and on the seventh day when he was doing suture removal, the wound got gaping, and he has to be still there in the hospital for another 1 week, so that rebridgment, wound toileting and rebridgment has to be done. Again, a second surgery has to be done. So what he was advised for 3 days became 2 to 3 weeks, and the bill became enormously high. The third one is central line associated bloodstream infections. So many times we introduce the thing in the central line so that we want to push lot of fluids, or we reserve it for dialysis. So these can also lead to infection. Then the ventilator-associated pneumonia. Here the patient was brought in for hemiplegia. He became breathless during the stay in the hospital, and ventilator was used with the consent of the patient's attender. And after 2 or 3 days, patient developed difficulty in breathing, high fever, and the X-ray and the CT chest showed he had pneumonia. This is also hospital acquired ventilator associated pneumonia. So other common infections are MRSA, methicillin resistant Staphylococcus aureus. This happens mostly to the uh, healthcare workers, even the doctor, nurses. We have the habit of doing like this, and the hospital infection with resistant Staphylococcus aureus gets lodged here. So, so if you take a swab and do the culture from the healthcare personnel, we can find out the doctor or the nurse has got MRSA. Same way, many times we use stethoscope routinely and hold the bell, the diaphragm of the thing, and keep one finger on the back side of the stethoscope in the bell region. If you take a swab from this thing, we can find out these methicillin resistant Staphylococcus aureus and other infections. So the causes of hospital acquired infections are bacteria, virus, and fungi. It can be many organisms are responsible for this, or it can be due to same bacteria, virus, fungus being introduced through contaminated equipment, or it can be due to poor hand hygiene or inadequate sterilization, or there can be antibiotic resistance leading to hospital acquired infection. The risk factor is not, it is not that everyone who gets admitted gets the infection. It is patient related factors, may be that age group, extreme age group, yeah, very young at the age group or very old, the extreme of age group, they are vulnerable for hospital acquired infection. Immune status, it is not necessary patient should have HIV, acquired immunodeficiency syndrome. Even diabetes can reduce the immune status. Even pregnancy can reduce the immune status, or any other underlying conditions like chronic kidney disease and severe medication can lead to patient-related factors. Hospital-related factors, prolonged ICU stay, prolonged hospitalization. It is better that patient becomes diagnosed with the right and treatment is correct, accurate, he can come out of ICU in few days and stay in the ward and get discharged within a week or 10 days. If it is prolonged, many times it leads to hospital acquired infection. And procedural factors like surgery, use of catheters can lead to other risk factors. So, hospital acquired infection has definitely has got an adverse impact. It, it impairs the patient outcomes, increased morbidity, or sometimes leading to mortality. Financial burden on healthcare system. So extended hospital stays are there. And when it is a private hospital, the bills keep on uh, clicking every day, and it leads to huge amount. And increased use of antibiotic. We have to realize that sometimes we start with the lower end of antibiotics, and when the patient is not responding, we go to the highest antibiotic. And one thing we have to realize that no new antibiotic has been discovered or invented in the last 2 decades. We are we are using the only the old antibiotics which have been invented or discovered. So definitely we have to resort to prevention strategies. For prevention strategy, anything has to come from above. It has to come from the hospital owners or the directors or superintendent, medical superintendent, like that. So we should have, for the success of hospital infection control, we should have a leadership support. Ensure that the governing body of the healthcare facility or organization is accountable for the success of infection prevention activities. Allocate sufficient human and material resources to infection prevention to ensure consistent and prompt action to remove or mitigate infection risk and stop transmission of infections. Ensure that staffing and resources do not prevent nurses, environmental staff, etc., from consistently adhering to infection prevention and control practices. Assign one or more qualified individuals with training in infection prevention and control to manage the facility infection prevention program. So we should have a designated person who is well qualified and trained. Empower and support the authority of those managing the infection prevention program to ensure the effectiveness of the program. To be a successful infection prevention program require visible and tangible support from all levels of the healthcare facility leadership. Second step is education and training of healthcare personnel on infection control. They might have been trained on patient care, administering the injections, monitoring the vitals, and other things. We have to educate and train them, all healthcare personnel, on infection prevention. Provide job specific infection prevention education and training to all healthcare personnel for all tasks. Require training before individuals are allowed to perform their duties and at least annually assessed. So we should have an induction training as well as refresher every year. Provide additional training in response to recognize lapses in adherence and to address newly recognized infection transmission threats, example, introduction of new equipment or procedures. Develop process to ensure that all healthcare personnel understands and are competent to adhere to infection prevention requirements as they perform their roles and responsibilities. Provide written infection prevention policies and procedures that are available, current, and based on evidence-based guidelines. It may be CDC or Hospital Infection Prevention Advisory Committee. Training should be adapted to reflect the diversity of the workforce and type of facility and tailored to meet the needs of each category of healthcare personnel being trained. It is not sufficient we train our healthcare workers. We have to train or even educate patient, family, and caregiver, even though they are staying there for a short period. Provide appropriate infection prevention education to patient, family members, visitors, and others, including the caregiver. So we have patient visiting hours. We have 2 hours in the morning, 2 hours in the evening, and we restrict the visitors to come in large numbers at any time they like that. Or when they are in the ICU, we allow the family members to see the patient once in the morning and evening and tell about the how the patient is, how he is responding to the treatment. These include information about how infections are spread, how they can be prevented, and what signs or symptoms should prompt re-evaluation and notification of the patient's healthcare provider. So instructional materials and delivery should address various levels of education, language comprehension, and cultural diversity. We can have posters inside the wards or rooms or even in the waiting hall. Fourth one is performance monitoring and feedback. Identify and monitor adherence to infection prevention practices and infection control requirements. Provide prompt, regular feedback on adherence and related outcomes to healthcare personnel and family leadership. Train performance monitoring personnel and use standardized tools and definitions. Monitor the incidence of infection that may be related to care provided at the facility and act on the data and use information collected through surveillance to detect transmission of infectious agent in the facility. So the performance measures should be tailored to the care activities and the population served. The fifth one is standard precautions. These include hand hygiene, environmental cleaning and disinfection, injection and medication safety, risk assessment with use of appropriate personal protective equipments like gloves, gowns, face masks based on the activities being performed. Minimizing potential exposure, example respiratory hygiene and cough etiquette. Next one is reprocessing of reusable medical equipment between each patient or when soiled. So standard precautions are basic practices that apply to all patients' care, regardless of patient's suspected or confirmed infectious state, and apply to all settings where care is delivered. These practices protect healthcare personnel and prevent healthcare personnel or the environment from the transmitting infection to the other patients. So we'll take up hand hygiene. Hand hygiene requires healthcare personnel to perform hand hygiene in accordance with the Centers for Disease Control and Prevention (CDC) recommendation. Use an alcohol-based hand rub or wash with soap and water for the following clinical indications. Immediately before touching the patient, before performing an aseptic task, or placing an indwelling device, or handling invasive medical devices. Before moving from work on a soiled body site to a clean body site on the same patient. After touching a patient or patient's immediate environment. After contact with blood, body fluids, or contaminated surfaces. Immediately after glove removal. Ensure that healthcare personnel perform hand hygiene with soap and water when hands are visibly soiled. Ensure that supplies necessary for adherence to hand hygiene are readily available in all areas where patient care is being delivered. So, unless hands are visibly soiled, an alcohol-based hand rub is preferred over soap and water in most clinical situations due to evidence of better compliance acquired to soap and water. Suppose initially we were providing soap and water. The thing is they have to move from the place where they are giving the uh, services to the patient, go to the um, sink, open the tap, wash it, and wipe it with the towel and come back. So this is an interruption to their work, and more than that, many times soap itself may contain fungus, or the towel used for wiping may be contaminated. Hand rubs, now we have instead of soap, we have hand rub. I mean, liquid soap. Hand rubs are generally less irritating to hands and are effective in the absence of a sink. So we have the alcohol-based hand rubs in the with each and every cot. So when we go and attend to a patient in a particular cot, we clean our hands with this alcohol-based sanitizer, attend on the patient. After finishing, again we use this. And many times we bill on the patient also for the things. Refer to the CDC guideline for hand hygiene in healthcare settings or guideline for isolation practices preventing transmission of infectious agent in healthcare setting 2007 for additional detail. Environmental cleaning and disinfection. Require routine and targeted cleaning of environmental surface as indicated by the level of patient contact and degree of soiling. Clean and disinfect surfaces in close proximity to the patient and frequently touch surfaces in the patient care environment on more frequent schedule compared to other surfaces. Promptly clean and decontaminate spills of blood or other potentially infectious materials. Select environment prevention agency registered disinfection that have microbial activity against the pathogens most likely to contaminate the patient care environment. Follow manufacturer's instruction for proper use of cleaning and disinfecting products, example dilution, contact time, material compatibility, storage, shelf life, safe use, and disposal. So, when information from the manufacturer is limited regarding the selection and use of agent for specific microorganisms, environmental surface or equipment facility policies regarding cleaning and disinfecting should be guided by the best available evidence and careful consideration of the risks and benefits of the available option. Refer to the CDC guidelines for environmental infection control in healthcare facilities and CDC guidelines for disinfection and sterilization in healthcare facilities for details. Next one is injection and medication safety. Prepare medication in a designated clean medication preparation area that is separated from the potential surface of contamination, including sinks and other water sources. Use aseptic technique when preparing and administering medication. Disinfect the access diagrams of medication vials diaphragms of medication vials before inserting the device into the vial. Use needles and syringes for one patient only. These include manufactured pre-filled syringes and cartridges devices such as insulin pens. Enter medication containers with a new needle and new syringe even when obtaining additional doses for the same patient. Ensure single dose or single use vials, ampules, or and bags or bottles for parenteral solutions are used for one patient only. Use fluid infusion or administration sets, example intravenous tubing, for one patient only. Dedicate multi-dose vials to a single patient whenever possible. If multi-dose vials are used for more than one patient, restrict the medication vials to be centralized medication areas and do not bring them into the immediate patient's treatment area, that is operating room, patient room, cubicle. When face mask, wear face mask when placing a catheter or injecting material into the epidural or subdural space, example during myelogram, epidural or spinal anesthesia. Next one is risk assessment with appropriate use of personal protective equipment, PPE. Ensure proper selection and use of personal protective equipment, PPE, based on the nature of the patient interaction and potential for exposure to blood, body fluids, and or infectious material. Wear gloves when it can be reasonably anticipated that contact with blood or other potentially infectious materials, mucous membrane, non-intact skin, potentially contaminated skin, or contaminated equipment could occur. Wear a gown that is appropriate to the task to protect the skin and prevent soiling of clothing during procedures and activities that could cause contact with blood, body fluids, secretions, or excretions. Use protective eyewear and mask or face shield to protect the mucous membrane of the eyes, nose, and the mouth during procedures and activities that could generate splash or sprays of blood, body fluids, secretions, and excretions. Select mask, goggles, face shield, or combinations of each according to the need anticipated by the task performed. Removal and discard PPE other than respirators upon completing the task before leaving the patient's room or care area. If a respirator is used, it should be removed and discarded or reprocessed if reusable after leaving the patient's room or care area and closing the door. Do not use the same gown or pair of gloves for care of more than one patient. Remove and discard disposable gloves upon completion of a task when soiled during process of care. Do not wash gloves for the purpose of reuse. PPE example gloves, gown, face mask, respirator, goggles, face shield can be effective barriers to transmission of infection, but are secondary to the more effective measures such as administrative and engineering controls. Next one is minimizing potential exposures. Develop and implement system for early detection and management. Example, use of appropriate infection control measures, including isolation precautions, PPE, or potentially infectious person at initial points of patient encounter in outpatient settings. Example, triage areas, emergency department, outpatient clinics, physician office, or at the time of admission to hospitals and long-term care facilities. Use respiratory hygiene and cough etiquette to reduce the transmission of respiratory infection within the facility. Prompt patients and visitors with symptoms of respiratory infection con- to contain the respiratory secretions and perform hand hygiene after contact with respiratory secretions by providing tissues, masks, hand hygiene supplies, and instructional signage handouts at the point of entry and throughout the facility. When space permits, separate patient with respiratory symptoms from others as soon as possible. Example during triage or upon the entry into the facility. During periods of higher level of community respiratory virus transmission, facilities should be considered having a everyone mask upon the entry to the facility to ensure better adherence to respiratory hygiene and cough etiquette for those who might have the infection. Such as approach should be implemented facility wide and targeted forward higher risk. Example, emergency department, urgent care units experiencing outbreaks based on the facilities assessment. Reprocessing or reusable medical equipment. Clean and reprocess, the disinfect or sterilize reusable medical equipment, example blood glucose meters and other points of care devices, blood pressure cuffs, oximeter probes, surgical instruments, endoscopes, prior to use on another patient when soiled. Consult and adhere to manufacturer instruction for reprocessing. Maintain separation between clean and soiled equipment to prevent cross infection. So, manufacturer instruction for reprocessing reusable medical equipment should be readily available and used to establish clear operating procedures and training content of the profession. The next one is transmission based precautions. Implement additional precautions, transmission based precaution for patients with documented or suspected diagnosis where contact with the patient, their body fluids, or their environment presents a substantial transmission risk despite adherence to standard precautions. Or adapt transmission based precautions to the specific healthcare settings, the facility design characteristics, and the type of patient interaction. Implement transmission based precautions based on the patient's clinical presentation, like infection diagnosis and example syndrome suggestive of transmission infections such as diarrhea, meningitis, fever, and rash, respiratory infection as soon as possible after the patient enters the healthcare facility, including reception or triage areas in the emergency department, ambulatory clinic or physician office. Then adjust or discontinue precautions when more clinical information becomes available. Example, confirmatory laboratory results. To the extent possible, place patients who may need transmission based precautions into the single patient room while awaiting clinical assessment. Implementation of patient based practice may differ depending on the patient care settings, example, inpatient, outpatient, long term care. The facility designs characteristics and the type of patient's interaction and should be adapted to the specific healthcare. Temporary invasive medical device for clinical manner. During each healthcare encounter, assess the medical necessity for any invasive medical device, example vascular catheter, indwelling urinary catheter, feeding tubes, ventilator or surgical drain in order to identify the earliest opportunity for safe removal. Ensure that healthcare personnel adhere to the recommended insertion and maintenance practices. Early and prompt removal of invasive devices should be a part of the plan of care included into regular assessment. Healthcare personnel should be knowledgeable regarding the risk of the device and infection prevention interventions associated with individual devices and should be advocate for patients by working towards removal of the device as soon as possible. Hmm. So even the IV line, when flown and other things, we change periodically. So we come to the last part, the occupational health. Ensure that healthcare personnel either receive immunization or have documented evidence of immunity against vaccine preventable diseases as recommended by the CDC or CDC's Advisory Committee on Immunization Practices required by federal, state, and local authorities. Implement process and sick leave policies to encourage healthcare personnel to stay home when they develop signs and symptoms of acute infectious illness, example fever, cough, diarrhea, vomiting, or draining skin lesions, to prevent spreading that infection to patient and other healthcare personnel. Implements is a system of healthcare personnel to report signs and symptoms, diagnose illness that may represent a sick to the patients and co-workers to the supervisor or healthcare facility staff who are responsible for occupational health. Adhering to federal and state standards and directive applicable to protecting healthcare workers against transmission of infectious agent or occupational safety health association, bloodborne pathogen standard, personal practice equipment standard, respiratory infection standard, and TB complaints. So it is the professional responsibility of all healthcare organizations and individual personnel to ensure adherence to federal, state, and local requirements concerning immunization, work policies that support safety of healthcare personnel, timely reporting of illness by the employees to the employers when that illness may represent a risk to the patient and other healthcare personnel, and notification to the public health authorities when the illness has public health implication or requires to be reported. So, we do have challenges in preventing hospital-acquired infection because of emerging resistant pathogens, compliance issues by patient health and healthcare workers, resource limitation. It increases the cost of care, patient population diversity. Future direction, innovation in infection control. We have to keep on innovating the things. See, we initially uh, the cleaning people used to carry a bucket and a mop stick. Nowadays, they use a trolley-like thing where they can have the mop stick dipped in the antiseptic things and mopped and dried like that. Even for a huge area, we have motor-driven vehicle also. Research and development, policy and regulatory changes, and collaboration and education are must. So, after the advent of this biomedical waste management since 2000, has brought on this hospital-acquired infection considerably. So, adherence to this waste segregation at the point of generation and biomedical waste management is of paramount importance. And I would like to reserve it as a separate topic in the time to come, maybe in the next month. I would like to have a separate topic on biomedical waste management. So, to summarize, the public and the government Government expects all the healthcare facilities, doctors, healthcare workers to observe safe environment for patient care, and they should not be the fomites, cause for spreading the infection or from one patient to another patient. So nobody will pardon or come again and seek the treatment once more. So importance of continuous vigilance and improvement has to be there. And call to action for healthcare professionals that we have to, it is our moral duty, or we can even say legal responsibility to provide infection free atmosphere in our premises. Thank you, Arpita. If there is any questions, I would like to answer.
Thank you, sir. Thank you so much. So we'll take the questions now. As far I know, sir, you have almost covered everything. Still, I think there are two or three questions. The first question is, what are the latest evidence-based practice for sterilization and disinfection of medical instrument and surfaces?
Yeah. Right. See, even though we have a lot of advertisement regarding domiciliary cleaning and other things, we have bulk purchase thing. We purchase these cleaners for keeping the environment and for cleaning the this one. So that should be a quality control thing for the suppliers who supply these antiseptics and disinfectants. So we should not go resort to a cheap brand and land up later on. So we should have things checking up the things. We can even ask them the quality whether they have undergone quality control. We can ask the certificate from the suppliers, and we should always use a um, quality antiseptics and disinfect. And wherever we disposables are used, they have to be disposed. They should not be reused again. Only those things which are reusable should be sterilized as per I told you. Each equipment comes with a manual how to clean the your instrument and use it at what interval you can use for the next patient. Suppose if you have only one endoscope and you have a long queue of your patients waiting for endoscopy, and just by dipping the endoscope in antiseptic lotion, even say 2% glutaraldehyde, for a very short period, does not serve the purpose. So we have to follow it. So we should have at least two endoscope and two trays for cleaning the endoscope. Use one, dip it in the 2% glutaraldehyde, use the other endoscope, then use it again. So usual minimum time, say half an hour, has to be there between usage uh, for after sterilization. So these are the things, and especially the ventilators when we use in the ICU. And just because another patient has become bad, you cannot just remove the ventilator from one person and introduce the things. And even the ventilators have certain disposable item where things which cannot be used for the same another for another patient. So we have to be quality conscious and safety conscious. And better, we have to read the manual. Whenever you have a new equipment, read the manual thoroughly. See, when a new drug comes, we always read what is the new drug, does it have the interactions, and does it have adverse effect, like that. Only after that we get convinced we use the new medicine for our patient. Same way, whenever you have a new model of equipment, you have to study the manual and use it. And better to have a biomedical engineer in tertiary care settings. Separate person to take care of the high-end equipments.
Right, sir. Thank you. Thank you so much for answering the query. There's another question. to prevent cross-contamination, how should we manage and isolate patients with multi-drug resistant infections?
Mhm. So, see, um, in government sector, we do have infectious ward thing, separate block away from the main block, and we shift the patient to the thing, maybe diarrhea ward, or even some of the patients. When I had done house agency, we had rabies patient where we do not have any drug to treat this rabies patient. We have to simply watch them dying, not able to take water, food, and see them dying. So we should have a isolation ward, better, or in a multi-story thing, we can have an isolation floor where we use have a separate floor or individual rooms like that, for infectious or infective patients. Then we have to isolate, and we have to use sufficient personal protective equipments. Whenever you enter that floor or enter the room, you should have protective equipments and use it and dispose it off. The thing is that coming in the morning wearing a PPE gown and using it for the entire day doesn't say a purpose. You may be protected, but not the people around you may be protected. So the simple hand washing has revolutionized. It's definitely revolutionized. Um we had only running water being provided, or a bucket with a mug was given for hand washing, and the ayah will pour the thing, and staff nurse will give the towel. But we were using the same towel during our 6 hours or 8 hours work in the wards. No, but the tissue papers and other things, disposable uh, paper towels and other things have revolutionized. Only thing is they have increased the cost. But when we produce it in larger numbers, the prices also come down. Hmm. See, if you want an ICU visitor to see the ICU patient, he should sell out 50 to 100 rupees and buy the shoes, cover, one gown, gloves, mask, like that. Even a cap may be there, required. He can, when he goes near the patient and speaks, definitely the patient will identify this person who has come to see him. So only the persons known to them are going to come and see and inquire. So it is high time we have these PPE kits even for the visitors. That is why many of the hospitals they have restricted ICU things, you know, visitors.
Thank you, sir.
Anything
Thank you
else?
so much. Yeah. Thank you so much, sir, for sharing such valuable information. Yes, a small step like hand washing technique can also bring revolutionary change. Right, sir. Sir, no, there are no more questions for today. So, with that note, we would like to conclude the session here. Sir, first of all, I would like to thank you for enlightening the topic with your wisdom, with your knowledge. And of course, thanks to all the audiences for attending the session, for putting up their questions and making it a successful one. So, thank you all. Thank you so much, sir, for putting your valuable time. Thank
Thank
you.
you. Thank you,
Thank
Arpita.
you. Thank you so much, sir. Thank you.